Good morning, everyone. My name is Köves-Dobszai, and my topic is the effect of obesity on the progression and the outcome of acute inflammatory diseases. I must confess at the beginning that I come from a rather interdisciplinary background, starting in political science, followed by healthcare management. But I usually like to think that it only supports my research in the medical field with a hopefully broader perspective. So my vision is aiding physicians in risk assessment and decision-making about obese patients, and to be able to do that, we are comprehensively addressing all factors related to obesity for deeper understanding the way they interact with each other. We have already conducted a meta-analysis on the correlation between body mass index and acute pancreatitis outcomes, and as a continuation of our previous work, we took other obesity-related factors into consideration, and we are looking at the effect of metabolic syndrome and its components on the outcome of acute pancreatitis, and in the second project on the outcome of COVID-19 in the registry analysis. So let me introduce my first project. We are all aware of the increasing mortality rates when acute pancreatitis becomes severe, and as obesity rates are increasing, so do the incidence of the related metabolic disturbances. So it is not surprising that the prevalence of metabolic syndrome has also reached 20 to 25% in the Western countries. All of these factors were already associated with a poor acute pancreatitis outcomes and even higher healthcare costs, and it may seem like we have sufficient evidence in the field. But these earlier studies were either meta-analyses concentrating on only one of these factors or cohort studies with relatively low sample sizes. So our aim was to do an analysis on the individual and synergistic effect of these factors at once. Our question was how metabolic syndrome factors affect the outcome of AP, and the 4 exposures that we studied were obesity, diabetes, hypertension, and hypertriglyceridemia. We have conducted a systematic search in 3 databases, and from almost 20,000 articles, we could include 90 at our final analysis. Here you can see a summary table of all our final findings with the factors, outcomes, and the corresponding effect sizes. And the statistically significant results are highlighted in light blue. However, I would like to walk you through the most important findings individually as well. At first, we wanted to update on our analysis on the effect of obesity on acute pancreatitis outcomes, but the included articles used very different body mass index cutoff values to define obesity. So we decided on combining overweight and obese patients and assessed the effect of excess body weight. And we saw that patients with an abnormally high body mass index are at significantly increased risk of developing both local and systemic complications, thus increasing the risk of severe acute pancreatitis and mortality as well. The second investigated exposure was hypertension, and we saw that malignant hypertension means a 2 times increased risk, or 2 times increased odds of mortality in AP. However, the risk for severe acute pancreatitis was not significantly increased. Although in the case of diabetes was significantly increasing the risk of developing severe acute pancreatitis, and it was also a predictor of the renal failure throughout the disease course. When analyzing the effect of hypertriglyceridemia, we did not only concentrate on hypertriglyceridemia-induced acute pancreatitis, but involved all patients who presented on admission with an even borderline elevated triglyceride level. And we saw that these patients have an almost 2 times increased risk of mortality and more than 2 times increased odds of developing necrosis. We also analyzed patients with metabolic syndrome, which means that these patients have at least 3 of these exposures that we investigated earlier, and saw that these patients have a 40% increased risk of severe acute pancreatitis. However, this result was mathematically not significant. And as you can see, 2 of these studies showed an association between mortality and met by while the other 2 studies did not, and the reason behind not getting an answer is the very low number of events in this case, so we will definitely need more studies to provide a stronger conclusion. So this was the first comprehensive meta to analyze all these factors at once. However, there was a high heterogeneity among the included articles, and there were relatively low sample sizes in the subgroups. Our results suggest that patients with metabolic syndrome are at a risk for a poor acute pancreatitis outcome and require a closer monitoring. And considering the high rates of acute pancreatitis recurrence, the lifestyle counseling and education of these affected patients is also very important. The manuscript was submitted to obesity reviews in April and is still under review, so we're waiting for the first decision. My second project is investigating the effect of metabolic syndrome factors on the outcome of COVID-19. The mortality rate of COVID-19 ranges between 3 to 7%, and this clinical spectrum ranges from an asymptomatic infection to mild respiratory tract symptoms to severe pneumonia and multi-organ failure. And earlier studies showed that comorbidities may cause a more severe outcome and poorer prognosis. And as I earlier mentioned, these MET factors are major risk factors in a number of other diseases. So our aim was to comprehensively analyze their combined and synergistic effect. Our question was how metabolic syndrome factors affect the outcome of COVID-19, and we investigated the same 4 exposures. And at this point, I would like to highlight that detailed analysis of registry data collected during the COVID-19 pandemic remains clinically important, as it may help us in identifying the high-risk populations in possible future outbreaks as well. For this analysis, I have used the coronavirus registry that Luca has already introduced, and the statistical analysis is still ongoing. However, we have some preliminary analysis. In the case of obesity and hypertension, both of these exposures were associated with a higher rate of severe and critical outcomes. However, from these 2, only hypertension was associated with an increased mortality rate. Considering diabetes and hypertriglyceridemia, we saw that both of these exposures result in a higher rate of severe critical and even fatal outcomes. We also plan to analyze if the number of factors present in a patient has any effect on the outcome. So we compared the metabolically healthy individuals to those who presented with 1 or multiple factors. And this very preliminary heat map suggests that there is a tendency of patients with multiple factors present have a higher risk for a poorer prognosis. But I have to emphasize that we are still before the multivariate statistical analysis, so we cannot tell yet if the number of factors have an independent effect or not. So to sum up with, my first project is finalized and currently under review. And my second project is expected to be finalized in September. Regarding my additional activities, I serve as a methodology supervisor for 3 students at the University of Pécs, and I also had the chance to act as the co-supervisor for one of our project students when writing her thesis. I also had the chance to present our results at multiple conferences in the form of posters and through oral presentations, and most recently I became the secretary of the pancreas section in the Hungarian GI Society. Thank you for your attention, and I would like to close my talk with the words of Abraham Lincoln: "Things may come to those who wait, but only the things left by those who hustle." Thank you.
Thank you for your presentation. Congratulations. Any questions?
Congratulations. Great talk. My question would be, in your second project, you mentioned the population is COVID-19 patients. Did you take under consideration if they are vaccinated or not?
Thank you for your question. These patients that we are analyzing were recruited into 2020 and 21. So in this period, only vaccination for healthcare professionals was available, and the general population was not vaccinated at this point. So this is something, we have a separate database of the 4th COVID wave in Hungary, but we will analyze those data separately in another part of the analysis.
Thank you.
My question is also about population, but about the first project's population. So you mentioned that you investigated metabolic syndrome patients, but is it an exact definition like metabolic syndrome, or is it differ from countries to country?
Thank you for your question. There are several different definitions for metabolic syndrome. The two most important, or the two widely accepted ones, are from the National Cholesterol Education Program and the International Diabetes Federation. And it usually involves the presence of at least 3 factors from the following ones. So it's mainly concentrated on obesity, mostly abdominal obesity, based on deviated circumference, some kind of impaired glucose tolerance, so it can be not just type 2 diabetes, but impaired fasting glucose or insulin resistance as well, hypertension, and some kind of dyslipidemia, so not only the high triglyceride level, but low levels of HDL cholesterol as well.
And could you put together this data?
Yes, we pulled together in the last part of the analysis when we analyzed metabolic syndrome and non-metabolic syndrome patients, but as you can see, there was a high heterogeneity in this analysis as well, and this is due to the fact that they applied a slightly different methodology when defining these patients.
Thank you.
Can I ask a question? You have to allow me. You're our leader. One problem with a correlation between pancreatitis and its outcome and metabolic syndrome is that in acute pancreatitis, you can develop some of the signs of metabolic syndrome due to the pancreatitis, like your abdomen swells. So hip waist circumference may not be indicative because it's due to pancreatitis. Hypertension can be due to pancreatitis. Dyslipidemia can be due to pancreatitis. So my question is, when did these studies determine the presence or absence of metabolic syndrome? Was that a pre-existing condition and it was made sure, or was it assessed while they had pancreatitis?
In all of these cases, these were pre-existing conditions.
Okay, so it was diagnosed before they had
Yes.
developed pancreatitis. Thank you very much.
Thank you.
Thank you very much. My question is about triglyceride levels. I noticed that you looked at triglyceride levels, but what was the reason why you didn't look at other lipid levels? What was the theoretical clinical consideration?
Thank you for your question. You are absolutely right. We was planning to analyze HDL, LDL, and total cholesterol levels as well, but these are really a lot less frequently reported, so we did not have enough data to do analysis on cholesterol levels, only the triglycerides.
Okay. Thank you, and congrats again.
Thank you.
For the presentation. I would like to ask you about the COVID-19 study. Have you looked at whether these patients suffered the first infection or you know, it was a subsequent infection following another one? So.
Yeah, so this in this first part of the analysis, this is really early on in the pandemic, and we did not analyze this individually if the patient has the first or multiple episodes. But I can say I went through all of the epicrizes of the patients included in the database, and I can say that most of these patients went through the first infection. But maybe we can. That's a good suggestion.
The infection was due to the Wuhan variant, or because in 2021, I believe there was already some other sort of, I don't know, part.
They are mainly the alpha variants of the COVID, and the second part, some patients with the Delta variant, but they are mostly affected by the alpha variant.
Thank you for this nice presentation. In the first part of your talk, you showed data about acute pancreatitis, recurrent pancreatitis. Is there any clinical data where the obesity is reduced, so the patients had weight loss, and can this affect the incidence of recurrent acute pancreatitis? So after acute pancreatitis, there is a weight loss, and can this reduce recurrent acute pancreatitis?
Thank you for your question. We did not come through any follow-up studies that would assess the effect of a lifestyle intervention or something like that in the case of these patients, but maybe that's a good research idea for the future.
Yes, you know that metabolic syndrome is characterized by a low state inflammation. Have you examined the role of cytokine level or CRP in the outcome of pancreatitis or COVID infection?
Yes, we definitely thought of this being a factor in modifying the disease outcomes, but these biomarkers were not yet investigated by us.
I have one question for the last analysis. I know it's preliminary, but you mentioned that you want to pool together like the outcomes, the risk factors in groups. Like you want to, if someone has more than one, do you think those are independent and they can be grouped like that and it's not going to cause any collinearity or something?
What we would like to see if the number of factors has an independent effect, or if
so it doesn't matter which ones, it's just like how many, I would say.
All of these questions are really important. So we would like to assess the independent effect of the outcomes or the exposures one by one, and also the number of exposures as well.